Good afternoon, everyone, and welcome to Grand Rounds. It's 1 o'clock on Thursday, so we'll get started. I suspect there's a few more people to come, but we'll get started now. So welcome back to this semester. I hope you've had a good Christmas break and it's not been too busy for you, which of course is it's been mental in the department, and we've had a really difficult time across all the hospital with the COVID workload. So I'm just a big thank you to everybody who's had anything to do with the COVID response, either on the front line acutely or everyone else who's made a change to how they work, what they do, where they do it, to support those people who are on the front line. So a big thank you to everyone for their support all the way through this difficult time. Now, Grand Rounds was meant to start a few weeks ago, but it's just been a little bit too much tight pressure to get things sorted. So I hope you'll excuse us for the slight delay in getting things back going again. But we are going again, and I have a program which looks very interesting, varied and exciting to go through the rest of this semester, and the slots in April are starting to fill up as well. I'm very pleased that Leslie Crichton has agreed to come on board with me to help co-chair the Grand Rounds, organise them. And as you know, she spoke last semester about global citizenship. She's the local lead for that. So she's going to be taking a lead on the citizenship type of presentations. To start the program this semester, we're going to start off with Dr. Pauline Austin, who's a colleague in the intensive care unit. We speak a lot with our links with COVID, but we're not going to talk about COVID today. We're going to talk about another very important part of Pauline's work, which is as the local lead for organ donation. So if you're new to this to Grand Rounds, please mute your microphones during the presentation. If you have any questions, please put them into the chat box, or if you want to ask a question in real life at the end, please put your hand up. This is all recorded and will go on to our YouTube channel by the end of the day, and you can watch previous Grand Rounds all the way back to 2015 on that YouTube channel. I'll put the link into the chat. So with no further ado, Pauline, thanks very much for taking time out to come and give this talk today. I'm looking forward to hearing from you.
It's probably best to unmute, isn't it? So thank you very much. I will share my screen, or try anyway. There we go. Okay, so thank you, Tom, for the introduction. As Tom has already said, I'm a consultant in intensive care and anaesthetics, and I'm also clinical lead for organ donation within NHS Tayside. And why am I doing an update on organ donation today? Essentially, it's been prompted by the forthcoming changes to existing Scottish legislation with organ donation. And from the 26th of March, the organ and tissue donation law in Scotland is changing to an opt-out system. And that's of importance to many of us professionally, but it also has, excuse me, implications for us personally. Organ and tissue donation remains a very personal decision, and you have a choice. And the change in law applies to everyone in Scotland aged 16 and over, so it's important that people are aware of the changes ahead. And the practice of organ donation has evolved greatly, and I thought this might be a topic of interest to the wider healthcare community. And additionally, I think it's a very welcome distraction to all things COVID. My slide on. There we go. So what I hope we can cover today in this short talk is really why we need organ donation, what our current practice is, what are the key changes with the new legislation, and we'll touch on some of the advances that have happened. So whilst we had many amazing medical advances, sadly there are still a vast array of conditions that lead to organ failure. And although our ability to support individuals with end-stage organ failure has advanced enormously, for many, transplantation is really the only hope of achieving a relative return to normality. So what's the need? This is Scottish data. It's pretty up to date. And as you can see, there are many people who are currently in need of a transplant. And some of those who are currently on the list are suspended. And reasons for being suspended include things like intercurrent illness, so being in hospital, being on holiday, chance would be a fine thing, and other life events. So the numbers are still pretty substantial. And again, these are Scottish figures. This is deaths on the transplant waiting list. And it can be seen that despite there being an active transplant programme, sadly, there are still people dying whilst they await a transplant. And the years are reported in financial years, hence the recent data is incomplete. And 2020-21 is really not representative of normal situation. And it's important to note that the deaths on the waiting list are an underestimate because they only really relate to those who are on the active transplant list, with many more dying whilst they're suspended. So really, from a humanitarian perspective, there's a desire to try and limit these deaths, hence the worldwide practice of organ donation and transplantation. So with one donor potentially being able to save or transform the lives of up to 9 people, it's really important that we consider organ donation where it is a possibility. And many of you will have seen in the press or in the social media or on TV the campaigns to raise public awareness. Every September, there's Organ Donation Week, where across the UK there's an emphasis placed on donation. It didn't have quite so high a profile last year for obvious reasons, but these are just some of the local events that have happened to highlight what's going on. And I think you'll see in the coming weeks that there's going to be a much greater public profile with respect to organ donation in advance of the new legislation. So ultimately, these campaigns are designed to educate and inform the public, to get people talking, encourage them to have a conversation with their family and friends, and to prompt people to register their organ donation decision, whether that's a yes or a no. So how does that actually work? So many of you will have seen or indeed carry a donor card. I still have one of the very old blue ones, which I think has my maiden name on it. But some of you may have the more up-to-date versions. So within Tayside, you can see, and these are the organ donor register figures for Tayside, you can see there has been a significant increase in the number of people who've registered a decision on the organ donor register. So from March 2015 to this year, to January, there's been an increase of 9.9% of the Tayside population who've opted in to organ donation. But the organ donor register doesn't just hold the opt-ins, it holds the opt-outs. And you can see that as of the 6th of January, there were nearly 2,300 people in Tayside who've opted not to donate after their death. So how do you opt in to the organ donor register? Well, quite commonly it's when you get your first driving licence, or when you sign up for a Boots Advantage card, when you register with a new GP, or you can go online and register your decision. And what you can then do is you can authorise for all organs and tissues, or you can individually authorise heart, lungs, kidneys. But if you have an opt-out, you're basically opting out to all organ and tissue donation. So despite a decade of initiatives and around 50% of the Scottish population joining the ODR, family refusal rates remain static. And I don't know if you can see it because it's hidden behind my cameras I can see, but in 2018-2019, the combined authorisation rate for donation was 64%. And that's slightly higher than previous years, but it's really far short of the ambitious target that we had set to have donation rates in the sort of 80 to 85% by 2020. And missed opportunities to donate are really highest around the authorisation process. And there's an annual family refusal rate of around 35%. And in Scotland, around 12 families each year do not support their nearest relatives' previously expressed desire to donate. So effectively, they override a prior expressed wish to donate. And I guess one of the key things we need to think about is, well, why do families say no? And common reasons for family refusals include the time taken for donation to proceed. And that can be anywhere between really probably 16 hours at the shortest, very shortest, to up to 24, often up to 36 hours for donation to proceed. Family are often unsure. They don't want additional surgery. They feel the person has been through enough already, and they might think it's against their religious or cultural beliefs. But since Wales introduced their opt-out system in 2015, their consent rate has risen from 58% to 75%, and they now have the highest consent rate in the UK. And we know that families who do support organ donation often feel very proud and find it a source of comfort. With those that refuse, potentially later regretting that decision. And I think it's important to say that there is a need, excuse me, for Black and ethnic minority donors. Apologies. And that's because organs are matched by blood group and tissue type, and people from the same ethnic group are much more likely to be matches. So how many transplants are undertaken each year in Scotland? And again, this is data from the last few years. And again, obviously the 2021 data is not reflective of usual activity. And it's really very evident that the impact of COVID has clearly been felt. There has been massive disruption to both donation and transplantation. And there's been a 27% reduction in deceased donors and a 60% reduction in living donation, with consequently reduced transplant activity. So it has had a massive impact, which is unfortunate. So whilst I hope to have set the scene and highlighted the need for donation and provided some context to our current practice, it's probably worth just taking a little bit of time to think about how donation works at present before considering the changes that are coming in March. So every year in Scotland, there are somewhere in the region of 60,000 deaths, but less than 1% would have died in circumstances that would mean their organs and tissue can be considered for transplantation. And there's great public misconception, and I think probably indeed professional misconception about who can or cannot become an organ donor, and even less is known about tissue donation. For organ donation to proceed, the patient needs to be on life support within an intensive care unit. Very, very rarely can this be facilitated in an emergency department, but as I said, that's incredibly rare. And I think it's really worth remembering that for every death that occurs in ICU, it must be remembered that this is a life lost and a tragedy for those who are left behind. So when we talk about donation, we're broadly speaking about organ and tissue donation. And the focus today is really very much on deceased donation. And again, to aid clarity, because I'm very aware that this may be relatively new material for some people, there are essentially two routes to deceased donation. So there's donation after brainstem death, so heart beating donation, and there's donation after circulatory death, so non-heart beating donation. And again, to clarify, donation after brainstem death occurs in those patients who've suffered an irreversible brain injury. So for example, somebody who's been in a road traffic accident, who's had a traumatic brain injury, or somebody who's had a subarachnoid hemorrhage from a cerebral aneurysm. And these patients have had brainstem death tests performed, and they fulfill death by neurological criteria. So these patients are on life support, but their heart continues to beat. Moving to donation after circulatory death, or DCD. So that was previously known as donation after cardiac death, but advances now mean it's possible to transplant hearts after they've stopped beating. So the term has moved to circulatory death. And donation after circulatory death can occur in those patients who are receiving assisted ventilation. A clinical decision to withdraw life-sustaining treatment has been made, and death is anticipated within a short period of time, so within 4 hours. And again, these are often patients who have suffered a catastrophic brain injury, such as after an out-of-hospital cardiac arrest. Okay, so ultimately, putting all that together, you've got a critically ill patient in ICU, and they are approaching the end of their life, and donation is a possibility. We should be considering organ donation. But we need the family to be aware that all life-saving measures are exhausted and their loved one cannot be saved. And it's important to stress that any decision on withdrawal of treatment is definitely taken independent of any consideration about donation. So how do we go about initiating the process? So there are well-established links with NHS Blood and Transplant, who employ specialist nurses in organ donation, affectionately known as SNODs, which is not the most flattering of terms, but does the job. And they were formerly known as transplant coordinators. And they're embedded nurses within hospitals, and their role is to promote good practice in organ donation and also to facilitate the process. They provide support and advice for the clinical teams, they support the family, and they coordinate the whole donation process. And we work very closely with nurses, the specialist nurses at the end of life, and spend time planning how we will approach families at what is obviously a very, very difficult time. So who can donate? Well, essentially, it's considered on an individual basis, with organs from people over the age of 80 rarely being transplanted. And that's because these are much higher risk organs. But ultimately, it actually depends on who is on the transplant list at a particular point in time. There are guidelines that exist for some organs, and the age limits can vary really depending upon how the patient dies. For example, a guideline maximum age for lung donors is the age of 70. But the specialist nurses very much have the most up-to-date guidance and have the ability to talk to transplant teams to assess potential donor suitability. There are very few absolute contraindications, but active malignancy and CGD are probably the main absolute contraindications. So the new legislation. So I said earlier that the reason for the talk was to give a general update, but also to highlight how there are some changes coming up with the new legislation. So the Human Tissue Authorisation Scotland Act was actually passed in 2019, but was due to come into force in autumn last year. But given the pandemic, there has been a delay to that to this spring. And that's largely because there needs to be a period of public information and education before they can introduce this. And the move to an opt-out system is part of a package of measures to continue to try and improve transplantation rates. And much of what I've already said still stands, but there are some changes that are definitely worth being aware of. And what I would say is that this is an incredibly complex area, and I've really just tried to distill down the key points that may be of interest to people. So March the 26th, that's the big day. So what changes on this day and how will it affect us? So as I've already alluded to, one of the principal components of the Act is the introduction of an opt-out or deemed authorisation and opt-out system. Wales, as I said, introduced this in 2015 and England introduced this last year. So we moved from a situation where we have to make a positive choice to opt in to organ donation to one where if there's no recorded decision, it will be presumed that you have agreed to be a donor when you die. However, great care has been taken into drafting the legislation to ensure that vulnerable groups are protected. So those who are under 16, those that lack capacity, and those that are not normally resident in Scotland are excluded from the legislation. And central to the Act is the duty to inquire. So our primary aim within ICU is obviously to restore someone to health and well-being, and we're committed to doing everything we possibly can to save a person's life. However, once it's been established that nothing more can be done, and that's been discussed with the family, there will then be a move towards starting sensitive discussions about the possibility of organ donation. And that's where evidence or information gathering is required to identify what the most recent views are of the patient. And that's usually conducted by the specialist nurse in organ donation. And ultimately what we're trying to identify is what the views of the potential donor are and ensure that they are listened to and followed. With respect to children, as I've already said, deemed authorisation does not apply to children under 16. For those that are less than 12, authorisation is required from somebody with parental rights and responsibilities. Between the ages of 12 and 16, the young person can express authorisation, so they can sign up to the ODR or they can make a written statement. But if they've not done so, then that responsibility lies with the person with parental rights and responsibilities. And there's also provisions within the Act for children under care of the local authority. So pre-death procedures. So as part of the donation process, certain medical tests and procedures are required to ensure that transplantation is safe, successful, and a suitable match for a transplant recipient. The Human Tissue Scotland Act provides for a dedicated statutory framework for carrying out pre-death procedures. And these are tests and procedures that may be carried out on a potential donor prior to their death to facilitate donation. Excuse me, sorry about that. So this would involve donation after circulatory death situations or prior to confirming death by brainstem criteria. And the purpose of pre-death procedures is to increase the likelihood of successful transplantation rather than as part of the ongoing care of the donor. And the Act also includes awareness raising duties about pre-death procedures, what they are and how they can be authorised. So it's to try and improve transparency of what is going on. So the Human Tissue Act allows for two different types of procedures, type A and type B. So type A is essentially a routine test, so something that you would expect, so blood tests, urine tests, a bedside chest x-ray. Type B are less routine, rare or novel tests, so bronchoscopy, CT or MRI. And these are all procedures that have potential to cause harm. So transferring a potential donor for a CT to assess organs puts them at risk of a transfer, and therefore that has to have additional authorisation. So whilst I put the Procurator Fiscal up here, and that's not really to do with the new legislation, I think it's probably worthy of mention. I'm sure you'll appreciate that there are a number of patients who come to the end of their life in intensive care in circumstances where their death needs to be reported to the Fiscal. And all reportable deaths need to be discussed, and no part of the body can be removed without prior consent. And the PF will normally try and permit removal of organs and tissue for donation, but clearly what they want to do is ensure that there is enough evidence available for any potential subsequent criminal proceedings or FAI. And often that just requires a few conversations between the Fiscal and ourselves to figure out what the best way forward is. So how does this affect our current practice? Well, in all honesty, it shouldn't really dramatically alter what we're doing. We will continue to look after the critically ill. We'll continue to strive to make them better. And when that's not possible, we will, in appropriate circumstances, consider donation. We'll refer to the specialist nurses, we'll approach families, and we'll ensure we put the patient's expressed wishes and views at the forefront. And only then, when appropriate authorisation is in place, can donation proceed. And I think it's really important to say that we would never ever proceed down a pathway of deceased donation in the face of family opposition. We would not do that. So what about advances? So organ donation and transplantation is not only dependent upon donors. There's been an equal and ongoing strive to improve organ utilisation to ensure the best possible outcomes of the organs that are transplanted. One of the biggest challenges facing transplantation is the ischemic time of the donated organs. So it's known that the longer the ischemic time, the poorer the outcomes. And there's been great emphasis on trying to minimise ischemic damage to organs. In brainstem death, where the heart's still beating, the organs are being perfused with warm, oxygenated blood up to the point of retrieval. During donation after brainstem death, the organs undergo cold perfusion before the organs are retrieved. Thus, the warm ischemic time is really very minimal. But in donation after circulatory death, the patient has gone through the dying process. So they have an inevitable period of low perfusion and an inevitable period of organ ischemia prior to organ retrieval. So in an attempt to limit the ischemic damage related to DCD, the research has led to the development of something called normothermic regional perfusion. So NRP is very similar to ECMO. There's a heat exchanger, there's an oxygenator, and there's a pump. And rather than perfusing the whole body as you would with ECMO, NRP establishes a regional circuit that perfuses only the sort of thoracoabdominal organs. And in the context of DCD, instead of rapid removal of abdominal organs, the regional circuit allows the abdominal organs to be perfused in situ. And the restoration of this oxygenated blood to the organs allows them time to recover from anaerobic metabolism and gives them just that little bit longer to I guess, pink up before cold perfusion, and therefore they better tolerate the cold storage prior to transplantation. It also means that organs can be assessed in situ and biochemically as well through blood tests, identifying if there are potential functional issues prior to transplantation. I think it's key to note that there are safeguards in place to ensure that warm blood doesn't perfuse the heart or the brain. And it's a novel technique, but it has dramatically improved organ utilisation in DCD. There is very little point in putting poor quality organs into a recipient if they're doomed to fail. So DCD heart. Like all organs, the need for donor hearts is vastly outweighs the number that are available. The hearts are a very precious commodity, and there are less eligible donors, and they are technically challenging transplants. The first transplants were from a non-heart-beating donor, and essentially we've come back round full circle with the transplantation of hearts from patients who've died from circulatory arrest. I think the UK is leading the way. There's been more than 100 DCD heart transplants carried out since March 2015, and the UK is a world leader. They've done more DCD heart transplants than the rest of the world combined. 17% now of heart transplants in the UK are DCD, so 17 to 20%. Scotland has lagged behind a bit, largely owing to geography and demographics, and the institution of a DCD heart programme is relatively new. Ninewells, however, has made history. We were the first hospital to undertake DCD heart retrieval in November 2019. Sadly, that heart wasn't suitable for transplant, but at the beginning of this year, we were the first Scottish hospital to undergo DCD heart retrieval that was subsequently successfully transplanted to a teenager. So that's one positive outcome. So what happens with DCD heart? Essentially, life-sustaining treatment is withdrawn and the heart is retrieved really pretty rapidly from the donor. It is then taken and placed on this system, it's called an organ care system, where the heart is placed in this box and it's perfused with blood. And what that allows is that it allows perhaps the use of more marginal donors. It extends the sort of preservation interval so it can be transported around the country, and it allows assessment of contractility and allows some recovery of heart function. And hopefully, if the next video works, if this works, let's see if I can get this to work. Oh, there we go. So this, for those of you who are able to see, this is not a human heart, but this is the same principle. The heart is removed, it's then placed onto this oxygenated circuit, and it can be looked at and assessed both macroscopically and biochemically. It's all in a sterile environment. The lid gets closed, and then the heart, as I said, is transported to distant sites for transplantation. And one of the beauties of that, as I said, is that it means that this heart is functioning. The heart is functioning, and it means that those surgeons that are taking out hearts from recipients have more time because the heart is still pumping and working and getting oxygenated blood. So what have we covered today? So we've covered the need for organ donation, we've covered our current practice, what the key changes are with the new legislation, and we've touched on some of the advances. There are many more advances, and there's an awful lot of research going on at present. But I think if I had to have a take-home message, my take-home message probably would be on a more personal level, which would be to think about organ donation and have those conversations with family and friends, and take time to think about what your decision would be and record that decision, whether it's a yes or a no. And if you want more information, there is the Organ Donation Scotland website, which has a whole heap of information. There's the NHS BT website. We have an embedded specialist nurse in organ donation within Tayside, and I'm clinical lead for organ donation within Tayside, and I'd be happy to answer any questions. And I'll stop sharing my screen now.
Pauline, thank you very much for that. That's all really interesting. Things that jump out to me, for kids, the opting in and opting out for kids. My eldest son got his driving license, so was able to opt in, and then the younger one, who's 15, was desperate to do something because he wanted to be involved in it as well. So I didn't know that at 15 you can go and opt in, and God willing, he won't need to donate his organs. But if anything came to it, then it's good to know that is an option. There's been one question from the chat from Fiona Muir in the medical school, who says, what advice can you give for someone who has signed forms for donating their body to anatomy examination for educational reasons, but is equally keen to donate organs?
Yep. So I guess, so I think ultimately it would depend on the situation that somebody was in at the end of their life. And obviously, as I've alluded to donate organs, you pretty much need to be in intensive care at that point in life. I guess you can still donate your organs. Whether or not thereafter the body would be suitable for donation to the medical school for anatomy examination, I'm uncertain, and that's probably something that would need to be asked of the medical school. I guess my question would be what value or there would there be then in a body for anatomy examination minus some organs? I would think there is still almost certainly value, but that I think I would have to pass that question back to the various sort of body donation programs.
Yeah, I think I'm going back a long time to first year at medical school for me, but I do remember there being at least one cadaver that was missing organs because of donation back then, and of course the students around that cadaver just moved to a different one when it came to the kidney that wasn't there.
I can't see why there would be any conflict there. I think obviously there is so small a number of people who are in a position to donate their organs, but I can't see why that body could not then go on to be examined by medical students. Absolutely not.
Topical question: Can organs be donated if someone dies of COVID?
No, is the answer to that, and that. Currently, there's extensive testing. Clearly, our current ability to facilitate organ donation is somewhat limited, and there has, as I said, there's been significant drop-off in donation rates because of the capacity issues within intensive care. As I said, the donation process can take 36 hours, and that at a time when we are well above capacity and in a very stretched system is unfortunate and means that we're not in a position to facilitate donation. But as and when we can, if that patient had COVID, they would not be in a position to donate.
I'm hogging the questions here, but I find this very interesting. Locally, so in Tayside, are we able to do the tissue donation as well as the organs? So are we donating corneas and the rest of the things that not solid organs?
Yes, there's a tissue coordinator. In fact, there's a couple. Sharon Muirhead is one of them. So there is an active tissue donation programme, and principally a lot of that happens from within A&E, but certainly the restrictions for tissue donation are often a bit tighter because tissue donation is a life-enhancing procedure, whereas organ donation is seen to be a life-saving procedure. So therefore, the restrictions around those that can donate tissues is really very strict, but it's not impossible. Corneas, there are perhaps less restrictions on, but certainly that is something that people could explore at the end of life if that was desired.
Yeah, I take your point about life-saving and excuse me, life-changing, but corneas are completely life-changing.
Absolutely,
and
we do facilitate that here.
Yes, that's really good. Ellie, one of our excellent trainees, has said, do you anticipate that patients might be moved to ICU to facilitate donation if not already a patient in there? So patient on high dependency, say, seems suitable, get them through to ICU so we can do the donation.
So again, as I said, for somebody to donate organs, they need to be already on life support. So they need to be intubated and ventilated. We wouldn't ever intubate or ventilate somebody purely for the purposes of facilitating organ donation.
Okay. Kevin McColmville has asked me to ask you, are there any other specific exclusion groups? Thinking of LGBT month at the moment. So are there any sort of anachronistic rules about homosexuality or anything like that?
No, there's a very, very comprehensive and really quite probing medical and social history taken by the specialist nurses in organ donation to risk assess. And there will obviously be bloodborne virus screens taken as part of those pre-death procedures. But no, as I said, there really are very few absolute contraindications. But clearly, what we want to ensure is that donation is safe for the recipient. We do not want to put them at risk. So there will be all aspects of life explored, and it can be quite personal.
Katie Hans is going to speak in a couple of weeks' time about the changes to the blood donation regulations that for this year, which have only very recently changed in terms of the ability for gay men to be able to donate blood. So that's, I think, where my question, Kevin's question stems from there. So that's good to know that that is really not an issue at all, and everyone is treated the same. Does anybody else have any other questions they'd like to pop in the chat, or just stick your hand up or unmute your mic? How many people in an average year, of which the last one has not been average, do we harvest organs from in Tayside?
Okay, so we retrieve organs from, or we refer patients. It's very case mix dependent, so that's something that can go up and down, but we will refer somewhere in the region of between 10, 15, 18, up to 20 patients per year. Of those that go on to proceed to donation, there may be 8 or 9, but not all of those will then actually fulfill or progress to organ retrieval. So some of those, for example, with donation after circulatory death, they may not die in the time frame. So there may be 20 referred, there may be 9 or 10 that proceed down that route, of which those that actually then have organs retrieved may be in the region of 5, 6. I think at most we've had about 8 per year in Tayside, but it is a significant workload, and we accept that there is enormous benefit for those receiving organs, but it is a significant workload within our unit, particularly at times when we are tight for beds. Okay.
The heart machine, that's something else. We're living in the future, aren't we, with that kind of stuff? Science. It is
truly, having been part of the first DCD heart retrieval here, it was quite astounding to see the heart being retrieved quite so quickly and then suddenly pumping on this machine. It's quite amazing.
The lungs are certainly pre-treated before going beyond transplantation, doing that for quite some time, and it's always another slightly freaky image of lungs inflating and deflating inside a bell jar. But the infusion of not blood into the lungs, but in other fluids to help develop the lungs have been a major improvement in terms of lung transplant success in that initial window. So the initial mortality has gone right down in lung transplantation because of that.
Yep.
One last question from Violet, who says, do you know if many people are registering to opt out? So has it made a difference yet?
So I think we often see peaks in people registering to opt out round about this time when there's all the sort of information and education regarding the change in legislation. Wales and England saw a sort of an uptick in the number of people opting out. But as I said, we're nearly 2,300 in Tayside who have opted out. And ultimately, I think it's making a decision and making that decision known. So the ODR is there to say yes or to say no, and that's the important thing.
Thanks very much, Pauline. That's really interesting stuff and really important. And I know you've been wanting to give this talk for about 6 months, and we've never managed quite to get you here. So I'm pleased that we got you here today, particularly as how busy you've been in the last couple of months. So thanks for taking the time to come and do it. I really appreciate it. And that's a great way to kick off the semester. Next week, Valentine's Day special, or at least as close as we can get to Valentine's Day, is the heart. So John Irving, consultant cardiologist, is going to talk about whatever happens to the broken-hearted. I don't know what he's going to talk about, presumably heart failure, but we will see. His talks are always excellent, well worth tuning in for. Same time, 1 o'clock every Thursday. The Zoom link is the same now, so you don't have to find a new link in the email. It's the same link every week. And everything goes up on YouTube if you want to check up on previous grand rounds. If you've written to me to say that you want to give a talk, bear with me. I'll get back to you and offer you some slots. And apart from that, take care, everyone. Have a good rest of the day. And thanks again to Pauline and her team. Thanks so much.